And what I know is Prof. Rane is doing one with the RF, and it's almost, I think the results, they have assessed the results, so he can tell you better, or Victoria, if you know something about it. And it doesn't work very well for incontinence, maybe a short term for mild, but not too much. It doesn't work for severe cases at all. And well, there are no randomized trials to prove it.
Okay. So now Dr. Rane is back. Kindly continue, Dr. Ajay.
I am so scared now. I don't know what's going to happen. So I'm going to rush through my talk. So
no, don't rush. We have enough time. Please take your time. Don't rush.
Okay. So I apologize to everybody who's really listening here. So I think what you need to, so you've got the levels. I think you understood the levels. I've spent a lot of time now trying to explain the levels. What I want you to now think about is correlations with anatomy. So if you see a level 1 prolapse, there can be only 2 types of prolapses with level 1. One is where the cervix is long, or 2 where the cervix is short. Now this is very important to understand, because if the cervix is long, that means you have no breakage of the ligaments. There is a stretching of the ligaments. There's a competition between gravity and the ligaments. So the cervix is becoming longer and longer and longer. People call it supracervical elongation. People call it cervical elongation. It doesn't matter. Basically, the cervix is long and you have got stretched ligaments. Beware of such a prolapse, because very long cervix means you think, oh, no problem, I'll do a vaginal hysterectomy and I will look after it. But the uterus is actually quite high up. So opening the pouches can be very difficult if you have a very long cervix and a short body. In Fiji, I have seen 11 or 12 centimeter long cervices coming out of the vagina, but the uterus is actually 6 to 8 weeks and it's high up. It virtually has no descent. So you have to understand that cervical elongation is because of non-breakage of the ligaments. Short cervix or a normal length cervix, you will see that it's a complete total collapse of pelvic support. So the whole uterus and cervix and everything is coming out into the vagina. While with an elongated cervix, you'll only find that the cervix occupies the entire pelvis, comes out of the vagina, but not the uterus. So I think it is very important to understand with level 1 prolapse, you need to decide, is this a long cervix prolapse or a short cervix prolapse? If it's a long cervix prolapse and the problem only is the long cervix, you cannot actually make this better by doing uterine conservation surgery. A long cervix will never remodel. So you have to do a cervical amputation. And if you're going to do a cervical amputation, you have to do that when a woman feels she wants to have a uterus conserved. But if she wants to have babies, don't amputate the cervix. It has huge problems later on when they fall pregnant. So why are they neglected procedures? Because level 1 prolapses usually are asymptomatic, okay? Level 2, we talked about bladder symptoms and rectum symptoms. Unless you have these symptoms, you cannot justify operating on a cystocele or a rectocele. There is no such thing as a mild cystocele or mild rectocele. And level 3, very simple. You have incontinence symptoms, stress incontinence with anterior level 3 prolapse, sexual symptoms for posterior level 3 prolapse. So you have to understand that first you need to know what is the level of anatomy pathology. What is the pathology? At what level is it? So if I tell you that a woman has a level 2 anterior problem and a level 3 posterior problem, you will say that she's got a cystocele, she's got difficulty emptying her bladder, she has got a bulge, she's probably got recurrent UTIs, and because she's got a level 3 posterior problem, she's complaining of vaginal looseness, maybe vaginal flightus. So every prolapse that you see, you must find out what level of anatomy has been disrupted. So that's the first thing you have to do. The second thing you have to do is something called stage of prolapse. So there's level of anatomical defect. Then the next part is the stage of prolapse. And Victoria here has drawn some pictures of the dreaded POPQ examination. A lot of people get extremely confused with POPQ, but it's not that difficult. It can be mastered. However, let me make this really simple for you. When you examine women with prolapse, you usually examine them in the dorsal position. So they're lying on their back, their feet are apart, and you ask them to do Valsalva, no coughing. Coughing braces the levators. I've told you this in the previous webinar. Valsalva balloons the levators. So when you examine a woman, you ask her to push, let the levators balloon, and then see what is coming out. Okay? Just look at the hymen. If there is a bulge within 1 centimeter of the hymen, at the hymen, or outside the hymen, within 1 centimeter of the hymen, at the hymen, or outside the hymen, then that is what is called a stage 3 prolapse. The only prolapse you should ever operate is a stage 3 and a stage 4 prolapse. Okay? Any other prolapse that you decide that it is a prolapse and you want to repair, you repair it only because you have got a very low bank balance. You're only doing it to make money. It does not help women. So the prolonged study quite clearly showed that women at the age of, after 20 years of follow-up with vaginal birth, these women were diagnosed with POPQ stage 2 prolapse, and the women said they are completely normal. So stage 2 prolapse, into inverted commas, is actually normal vaginal mobility. So remember, vaginal mobility is not a prolapse. It is a functional part of a normal vagina. That's number one. Number two, we get referrals saying, oh, Professor Rane, please see this lady. She's got a cystocele, rectocele, enterocele, and all these women think all these seals are living inside her vagina. And they're probably clapping and having a good time. And she comes and I say, so, okay, what's your problem? And she goes, I don't have a problem. So what happened? My GP was doing a pap smear and he says, I've got all these seals living inside my vagina, right? So asymptomatic vaginal mobility should not be interpreted as prolapse. That's number two. So asymptomatic prolapse, do not touch, leave alone. Number three, invisible prolapse. Invisible prolapse means patient says, I've got a prolapse. So you say, okay, examine, please push harder, can't see prolapse. Okay, then standing up, try and examine. Then examine her at the end of a gym session. Then examine her at the end of the day. And if you cannot see the prolapse after that, then you must have what is called a little black book. Send that patient to your worst enemy because this patient is never going to get better. She has totally unrealistic expectations of her vaginal anatomy. So beware of the invisible prolapse. So now, in essence, you need level of prolapse, stage of prolapse, symptoms of prolapse. And all you need to do is use your fingers and your eyes and your ears to examine prolapse. You don't need any fancy equipment. All you need to do is put your 2 fingers on the posterior vaginal wall and ask the woman to strain. If there's a bulge coming out, then it's either apical or anterior. You can put your 2 fingers up like this in the anterior vaginal wall, ask her to strain, and if something is coming out, it's either apical or posterior, and then you can decipher whether there is an apical component to it or not. Now, The important part to try and remember is, what is the length of the posterior fornix? The posterior fornix is 10 centimeters in length. The anterior fornix, so this is the posterior fornix, point D. This is the anterior fornix, right? The anterior fornix is 7 centimeters in length. How is this possible? Posterior fornix 10 centimeters, anterior fornix is 7 centimeters. The other 3 centimeters is taken by the cervix. So what you have to understand is that anterior prolapses have a 50% associated apical defect. So if you have a cystocele, if you do not repair some kind of apical support during your repair of a cystocele, you are going to get a 25% recurrence. So anterior apical fixation is very important, okay? Posteriorly, it's the other way around. Posterior is very easy to fix. You can do any form of plication. The recurrence rates are very, very low. So I think it's important to understand that anterior prolapse has a 50% association of apical prolapse. Posteriorly, the most important thing you should not do, especially for level 2 defect, which is here, that's a rectocele. You see, that's the rectocele now, is never ever bring the levator muscles together. Levator myography is a very bad operation. It gives patients, more than 50% patients, dyspareunia. So please do not do levator myography. We're moving on quickly because we've got lots of questions, I know. So then we say, okay, would you do urodynamics on patients who have got genital prolapse? I know that 90% of you do not even have urodynamics. The question really is, if you actually reduce the prolapse and ask the woman to cough and she leaks, that is called occult stress incontinence. So she's not symptomatic. She's not saying, I've got stress incontinence. She's basically saying, I've got this big bulge. I want you to repair my bulge. But you examine the bulge, you reduce the bulge and ask her to cough and she leaks. What do you think is going to happen after you repair the prolapse? Patient's going to become incontinent. She's going to say, doctor, what sort of operation have you done? I had no problem with leakage before. All I had was this bulge. The bulge is gone, but now I'm leaking all the time. So urodynamics could be something you would consider if you demonstrated occult stress incontinence. Or if you have occult stress incontinence, you would say, how would it alter my management? Some people might say, so there's a 50-50 opinion. 50% of people would tackle the incontinence at the same time. 50% of people like me will do it as a 2-stage procedure. How does it alter your counseling? Like I said before, you will tell the patient, ma'am, you've got this bulge. I want to repair it. But there is a risk that your incontinence may be unmasked. This is not a complication of the operation. This is the fact that at this moment in time, you're not incontinent. But as soon as I repair your prolapse, it may unmask. So you need to counsel them. The last important point that I wanted to make is 20% of patients who you diagnose genital prolapse are underdiagnosed before surgery. So what happens is you examine them in the clinic, you tell them to push, you see this prolapse, that prolapse, you put them to sleep or you give them a spinal and the whole thing falls out. So 20% of women have an underdiagnosis of prolapse preoperatively. So you need to have some global consent when you manage uterovaginal prolapse surgery, because you might start by consenting the woman on an anterior repair, but if you have the whole uterus coming out, if you have a rectocele, then what are you going to do? So I think you have to be very aware of the fact that 1 in 5 women that you are going to operate on for genital prolapse are underdiagnosed preoperatively. Very, very important. There's 353 participants. I just feel enormously honored. Okay, now the other part is pelvic floor ultrasound. All of you in India have got ultrasound, and you all do ultrasound, but none of you do transperineal ultrasound unless you are really interested in urogynecology. I am telling you the other way around. Female anatomy can be most easily seen well when you do a transperineal ultrasound. You can just put some jelly in a glove, put the abdominal probe inside the glove, put some jelly on the outside of the glove, and put it on the perineum. It is a bit upside down initially, but once you see it, it'll be so easy for you to actually see what type of prolapse it is, because you examine them, you are not sure, is it an enteroceal? Is it a high rectocele? Is it a cervical prolapse alone, or is there an associated cystocele with it? But transperineal ultrasound, you can see this so much better, so much better. You'll save yourself a lot of problems later on. How does it assist management? Well, basically, whenever Victoria, my fellow, is not sure what type of prolapse it is, we'll do a scan. And 99.9% of the times, we will be able to diagnose what exactly is the problem in that genital prolapse. Okay, so very, very short, you have to talk to patients with genital prolapse about options. You cannot just say, I'm going to do surgery. There is no such thing as heal by steel. Every person is not just operated. Although that is really good for your bank balance, that is not the preferred treatment for every single patient. So the first treatment is do nothing. You can actually watch a prolapse. Conservative management and re-examining the patient every 6 months is a recognized practice of treating prolapse. Your main concern is, oh my God, she's going to go to someone next door and they're going to operate on her. Let her go. It's okay. You're not starving. So remember, longitudinal survey of a prolapse is a recognized treatment of genital prolapse. Do nothing. Doesn't mean you're ignoring the woman. You're basically saying, madam, you have a stage 2 vaginal mobility of the anterior compartment. You don't have any voiding dysfunction. You don't have any recurrent UTIs. You don't have sexual dysfunction. We can watch this. We can give you vaginal estrogen. We can give you some pelvic muscle therapy, and then see how you go in the next 6 months. Same thing again, conservative treatment. Conservative treatment means let them do pelvic exercises, let them get fit, lose weight, use vaginal estrogen. Which patients? Again, the same thing. Those borderline patients where you stage 2, maybe stage 3, not very symptomatic. But remember, for how long do you give conservative treatment? 4 to 6 months only. So you say, look, I'm going to give you all this stuff, all this education. You need to try this. If you don't get better in 4 months, come and see me, we'll operate. Or we'll put a pessary. Pessary. There are numerous pessaries. We only use 2 types of pessaries. We use a ring pessary or we use a shelf pessary. Shelf pessary is basically for older women who are not sexually active, who have got massive prolapses, but they do hold inside very well. But you've got to keep changing them every 3 to 4 months. Otherwise, they'll erode, they'll cause fistulas. But ring pessaries do not fit every single patient. You'll have lots of patients who come with the pessary in their hand saying, okay, you put it in yesterday here. Lovely, you can have this one. So you try a bigger size, then you try a bigger size, and it doesn't work. And last but not the least, what we have been taught is surgical management. Surgical management is very important because a lot of us believe that 60% of genital prolapse patients do very well with surgery. And now we're going to talk about surgery for the next 7 minutes. Okay, so let us go level by level and see what operations are available. And then you, in your heart, have to think, which of these operations can I do? And those are the ones you should keep doing. Okay? So if you have a level 1 prolapse, no uterus, you can do sacrocolpopexy. If you have a level 1 prolapse, ileococcygis fixation. Ileococcygis fixation. Ileococcygis is the muscle below the sacrospinous ligament. So it's not a very high level of fixation. So we only use it for rectoseal, rectoenteroseals. Sacrospinous ligament suspension is a transvaginal approach for level 1 prolapse. Sacrospinous ligament suspension can be done with an anterior approach, or it can be done with a posterior approach. So if you do it for an anterior approach, it's usually for recurrent stage 3, stage 4 cystocele. Uterosacral ligament fixation. Very, very good operation. Mangesh Narwadkar does it. He's a good surgeon. A lot of other people do it. Problem is, it has got a finite but definite risk of ureteric obstruction. So you need to know how to do a cystoscopy. You need to know how to do methylene blue or whichever indigo carmine dye intraoperatively to make sure you haven't tied the uretazole. And of course, vaginal hysterectomy and a high McCall's procedure. This is our procedure of choice. Our first go-to operation is a vaginal hysterectomy and high McCall's caldiplasty. We have got a huge series of more than 1,000 patients. Our apical recurrence rate after vaginal hysterectomy and McCall caldiplasty is less than 5%. And I think it's a very, very good operation, something you should learn to do very well. These are your apical operations. Then next thing, you go to level 2. Level 2, you have got anterior, which is a cystocele. Now, fortunately for all of us, 60 to 70% of cystoceles are midline. And Professor Raja Maheshwari and I had a little bit of difference of opinion, but she said 60 to 70% of cystoceles are paravaginal. I think the truth is somewhere in the middle, so we don't have to argue. But the bottom line is, for every single anterior repair that we do some kind of apical fixation. And that I think is very important. Now, you can do laparoscopic paravaginal repairs. You can do anterior colporrhaphy plication. I don't do any anterior colporrhaphy plication on its own. You have to add some kind of apical support with it. And we have two different methodologies. One is something called the midline plication of the cardinal ligaments, and then the midline plication of the pubocervical fascia, the Musprack operation. And the second one is an anterior approach to sacrospinous fixation. Posteriorly, you can do what's called a posterior plication, colporrhaphy, site-specific repair. Transanal repair is not supposed to be as good as our standard posterior repair, but no levators are bought together. No levators. Please do not bring levators together. Level 2 is a fascial defect, not a muscular defect. Do not bring the muscles together, full stop. There is a word I've mentioned here called colpoclysis, an operation that a lot of people think, oh, it's not sexy enough. But it is one of the most practical operations for palliative cure of large neglected prolapses in older women. Of course, they need to know that you're going to close their vagina, that if they want to be sexually active, vaginally it's not possible, but of course they can kiss and cuddle and hold hands. But the important part is this is an amazing operation, which takes very little time. It's highly effective. And, usually these women who have in nursing homes, neglected prolapses, contaminated with feces and urine. They're getting all sorts of problems because of this prolapse. And a colpoclysis can make a huge difference to their quality of life. So do not forget colpoclysis. It's a very, very nice and easy operation. And then level 3, for level 3 anterior, you can do a mid-urethral sling or Birch colpo suspension, laparoscopic open. For level 3 posterior, you can do what's called a perineoplasty, not a perineorrhaphy, a perineoplasty. Why is this important? One day I'm going to make a video of it. Perineoplasty is probably the hardest anatomy to try and understand. So my fellows can do all the operations that I've listed, but this operation is an operation that I choose to do myself, or very rarely under supervision, I let my fellows do it, because this is a very, very difficult anatomy to do correctly. You can just bring it all together and you think you've done a good job. But to do it correctly requires a very detailed understanding of the 3 levels of the perineal muscles, the urogenital diaphragm, the levator muscles, the continuation of the perineal muscles with these sphincter corrugator cutis. And that, I think, is something that people don't do very well. So remember, for level 1, you have different operations. Level 2, you have different operations. Level 3, you have different operations. Why is this important? This is important because when you have a prolapse, you may have what's called a multi-compartment prolapse. You might have level 1 prolapse, level 2 prolapse, level 3 prolapse, or level 2 and level 3, or level 1 and level 3, or level 1 and level 2 in various combinations. Always start with the lower level. So if you've got level 1, always start with number 1, then go to 2, then go to 3. Don't start with 3, then go to 2, then go to 1. Wrong. Start with 1, then go to 2, then go to 3. So there is a method in how you actually approach each prolapse. Also, we use a lot of local anesthetic with adrenaline. You can use saline with adrenaline. It's called hydrodissection, because we do not peel the vagina like you have been taught with the gauze. You keep peeling and keep peeling and keep peeling. It's not an onion. It's not a banana. You have to come inside what is called the viscous fascia interface. It's quite thick. When you're at the viscous fascia interface, your repairs are so much more robust. Also, simple. For fascial plication, please use PDS, not Vicryl. Polydioxone lasts for 12 weeks, very good results. Vicryl will last for about a week, not so good results. So use, and try and avoid using permanent sutures unless you are doing it for a 3rd time recurrence or a 4th time recurrence. So try and avoid Proline or Ethibond unless you are used to it and it's a recurrence. So don't use Ethibond. Use PDS for fascial plication and Vicryl for vaginal closure. Hysterectomy or no hysterectomy? We are coming to the end now. A lot of people do what is called the Werksberger approach. You've got McDonald's in India as well. So they have one piece of bread and they have another piece of bread, and in between they put everything, the patties, the pineapple, the beetroot, the onions, the chutney, everything. So same approach has been taken in genital prolapse. Any woman may have any prolapse, but she has a vaginal hysterectomy, anterior repair, posterior repair, perineoplasty, sacrospinous fixation, mid-urethral sling. It's not a burger. You need to do the surgery that the patient needs. So there is very little evidence to support taking the uterus. In fact, if you have a level 2 prolapse and you do a vaginal hysterectomy, you jeopardize even the level 2 prolapse integrity. There's also evidence to show that during sacrocolpopexy, you shouldn't do a hysterectomy. And that's because there's increased risk of mesh erosion, etc. But I think the important part to understand is not every prolapse needs a hysterectomy, and not every hysterectomy is for prolapse. It's as simple as that. So, but you must understand If there is cervical elongation, conserving the uterus is very, very difficult. You have to understand that, and you can counsel your patients about it. If the cervix is elongated, then conserving the uterus is very, very difficult. Okay? Good. Last part is failures. If you have a level 1 failure, vaginal route, would you go laparoscopic? Would you go open? Level 2 failures, usually, if you have posterior failures, then it is very important that you do what's called a DPG, a defecation proctogram. If you have a level 2 anterior failure, then that's probably because you haven't done an apical fixation. Level 3 failures are rare. Obviously, if your sling fails, you can look at doing another sling. Perineoplasties very, very rarely fail if you do them properly, but it may not completely cure the sexual dysfunction. Here are some references. We can share them with you later. And I'd like to thank you very much. And you're very welcome to ask questions. We are here for another, I got 2 fellows as well. So what I'll do now is I'll stop sharing my screen and let's start having some fun. Who wants to have fun?
Everybody wants to have fun, and Dr. Rane, thank you so much. You gave a very, very practical insight into such a complex subject. I'm happy all the 400 participants, they must be really very happy that they joined you for such an interactive webinar. I know you are here. I'm not leaving you for another 30-40 minutes because there are so many questions, and I am shooting you with one by one. Yes.
Okay, Dr. Victoria, you need to come alive. Dr. Victoria needs to come alive, and Dr. Tanvir needs to come alive. Very good.
Yes. So first question is, what is the role of, they want to know how to do Kegels exercises, any links, how to teach patient the correct way of doing Kegel exercise.
Okay. Victoria, what do you think? How should we teach people to do Kegel exercises correctly?
So I think you've talked before about the muscles that you can actually contract voluntarily. And I personally would refer someone to a physiotherapist because I don't think that we do it well or have the time to commit to it to get people to do it properly.
Good point. I'm going to stop you there. So what Victoria is saying is, we don't have the time. So it's like managing diabetes in pregnancy. Of course, you know how to manage diabetes because you have learned that as a doctor, but you'd rather send the patient to an endocrinologist in pregnancy. You don't have the time. So Victoria is very correct. When we have the facilities to have a physiotherapist, you can send them to a physiotherapist. I think in Hyderabad, it's probably the same, Dr. Tanvir, I presume?
Yes, Prof.
Okay.
Yeah.
But I am now telling you that you don't have a physiotherapist, that you live in a very small village next to where I was living for a long part of my life. You're in Jalgaon. No physio, but you are a dedicated pelvic floor surgeon who wants to teach Kegels to your patient. How would you go about doing that? And I'm not going to put you in the spot because I think you'll start hating me earlier. The most important thing you need to do, yes, Lakshmi?
Yeah, because you have to tell us, because in India, not every practicing gynecologist has the facility of having a physiotherapist. So it is we as a gynecologist who teach them how to do Kegels exercises.
Correct. And it is we who should learn by using 2 fingers.
Yeah, we have to teach them. Yeah.
You have to examine the patient vaginally. That's the most important thing. You have to put your fingers on the posterior vaginal wall and ask the woman to squeeze your fingers. The fingers that are in the vagina, not the fingers that are in the other hand. Okay? And so, depending on whether you can feel a flicker or a slight squeeze or a moderate squeeze with elevation of the posterior vaginal wall or fractured fingers, That is the grade. It's called the Oxford grade of pelvic floor strength. But then what you're doing is you're actually identifying the muscle for the lady, right? And it's that muscle she needs to identify and slowly start working on it. See, yesterday someone was saying, oh, now we have got vaginal cones that we buy cheaply and we give it. I can tell you that vaginal cones basically put your toes at risk. Because if a woman does not have any vaginal strength, she puts the cones in and they fall on her feet and she gets black toes. Hematoma of the toe is a known complication of vaginal cones. So I think we need to learn how to do a pelvic examination and how to examine the pelvic muscle tone, how to actually, Abdul Sultan gave a fabulous talk yesterday about anorectal tone. He's saying if you don't have an endovaginal scan, doesn't matter. Teach your finger. We have to teach our fingers to learn how to do pelvic muscle exercises. So that's the answer. The answer is do a PB, assess pelvic floor strength, see the patient every couple of months to make sure she's doing the right thing.
Dr. Rane, this is what when she is with you in your clinic, but at home, can we tell her when she is passing urine, she has to hold it, then pass, then hold it, then pass? I mean, is this the correct way of telling her what she is doing at home? How she will know whether she is correctly contracting the correct muscles?
I know, but stopping and starting your stream is not a game. It's only children that play with such a game. Actually, have you tried it yourself, Lakshmi? I, as a male, have tried it. It's very hard. It's very hard. It's very hard to stop your stream halfway through and then keep going. Stop, start, stop, start. You can use that technique to get an understanding of where the muscle is, but don't do it as a habit.
But how she will know if she is contracting correct muscles?
Yeah, so the only way you can do that is so she can try to stop her stream, and that is the muscle she needs to use to contract, relax 10 times, 3 times a day. This is not a gym. You can't suddenly become very, very strong with pelvic muscle exercises. So slowly they have to recruit that muscle, very slowly. So that's why they get very disappointed, because within 3 months, correct, someone said you should talk Mula Bandha Asana or Three Bandha Asana. Three Bandha Asana can be taught to even a 5-year-old. Indian yoga has taught how to use pelvic muscles very, very well. But now it's the white people who are teaching the Indians how to do yoga, which is so shameful, you know. And I think this is where we have gone wrong. And that's why I like the International Yoga Day, which was yesterday, I think, you know. But yes, the understanding of the pelvic muscles are very important, because if you don't teach them properly, all they do is squeeze their gluteal muscles.
Yes.
And then they all look like Serena Williams, because Serena Williams has got massive gluteal muscles, very strong legs she has got. But we don't want strong gluteal muscles, we want strong pelvic floor muscles. So I hope that answers your question about how we teach.
You are a very good surgeon, I know, but there is a question that what is the role of vaginal estrogen, local vaginal estrogen as a conservative treatment, and for how long it can be advised to the patient?
So let's see what Victoria has to say in her 6 months experience with us. Vaginal estrogen, how long for and on which patients?
Yes, yes.
So that was going to be my question of the person who's asking the question, is vaginal estrogen on who? And someone with stress incontinence or someone with a huge prolapse?
Prolapse. We are talking on prolapse. STY, he finished last webinar.
You were there.
We prescribe vaginal estrogen to almost everyone. But I think that we don't think it's going to make people's prolapse necessarily better. And if we use it, it's part of conservative treatment. And as Prof has said many times, for a limited amount of time, and his set time period is 4 months.
Correct. So we will use vaginal estrogen for 4 months. That is to improve the quality of the vaginal epithelium to improve the tone of the vagina to some degree, to improve the vascularity of the vagina to some degree, to improve the moisture of the vagina to some degree. But I actually sincerely believe that most women after the age of 54 probably should use vaginal estrogen every so often in their normal lifetime. Why? Because even if you take conventional HRT, it does not work on the genital tissues. It does not work on the genital tissues because they have got a different receptor called ER beta. We've done lots of research on this. Two types of estrogen receptors, ER alpha, ER beta. ER alpha is the ubiquitous estrogen receptor, usually present all over the body, sensitive to estradiol. ER beta, on the other hand, is present in the hippocampal gyrus of the brain. Don't ask me why. God made it that way. And the vagina, and it is more sensitive to estriol. So vaginal estrogen, yes, give it to every single woman over the age of 54, not a problem, not more than 4 months. You have to recheck because vaginal estrogen does not cure prolapse. It just makes the vaginal caliber, vaginal tissue quality so much better, so much better. So conservative treatment, yes, use vaginal estrogen. Thank you.
I just want to add here, because in India, it's a OTC drug. And once a gynecologist prescribes topical estrogen, our patient goes on buying it on their own and they are using it for years together. So here is a tip to all my Indian colleagues that whenever you are prescribing vaginal estrogen, please write in your prescription that this prescription is valid for 3 months, 4 months, whatever, so that when patient goes and buy on her own, no chemist or pharmacist will be able to give her. And as Dr. Rane has rightly pointed out, we have to call her. But they don't turn up, Dr. Rane, because they start feeling good and they get it on by their chemist. They don't come to us for follow-up.
Yeah. So a lot of people have asked us the question, is there any harm in taking estriol? And in fact, ACOG has just released a statement saying that estriol is even safe in women who have got breast cancer because the actual systemic absorption of this is actually not, is virtually zero. So estriol you can use even in women with breast cancer. This is not me, this is an ACOG statement. I'd like to answer this question of Dr. Ang. And Dr. Ang asks, is it a term, global pelvic floor failure? And it is very interesting because there is such a thing. I'm sure you've seen prolapses where everything is hanging out. It's like the entire vagina has been turned inside out. The uterus is hanging out, the cervix is hanging out, the bladder is hanging out, the rectum is hanging out. So everything has been turned inside out. Can you imagine what all has happened here? You have ligamentous failure, you have fascial failure at level 2, you have ligamentous failure at level 3, you have muscular failure at level 3. That is what would be called a global pelvic floor failure. Yes, these patients are not easy to treat. They're not easy to treat.
You have jumped. Let me take questions.
Sorry, my apologies.
Dr. Rane, because everyone is waiting for you to answer their question. So Dr. Manisha has asked you to explain the technique, the tips and tricks for sacrospinous fixation.
Oh, okay. Let's see. Tanvir, you want to give us some tips and tricks for sacrospinous fixation? Because Victoria also has done a few with me. What are the tips that you would say are important?
Just
very important during your training.
Prof, I haven't done any with you, but I did watch you do a good number of them. So I would say that what I've seen you do an anterior repair and you do a bilateral. And so I think your fascia, your dissection is very important. hydrodissection is very important, as what aquadissection, and yeah, the right plane.
Okay, and Victoria, what do you think?
So I think it doesn't really matter whether you go anterior or posteriorly. I think you are using, as Tanvir said, so first using hydrodissection to help with blood loss and establishing your planes, and then using blood dissection to develop the space down to the spines. I think then you want to make sure that not only can you feel your spines, but also that you can feel the ligament medial and superior to that. And then your device, there are many devices that don't fire properly. And I think Prof's the only one that I've seen use so he uses a Capio device, rinses it sort of first and pushes the trigger to make sure it's going to fire properly, and then loads the suture, making sure that the bullet is completely loaded in the device and you can't feel the sharp tip of it. Then you're going to use, so if you're going to the patient's left-hand side, you're going to use your left hand to protect either the rectum or the bladder. And if you're going to the patient's right-hand side, you're going to use your right hand to, again, protect the bladder or the rectum. And in doing a few of these with Prof now, he makes you say out loud, finger on the spine, Capio on the spine, finger 1 centimeter medial and cranial to the spine, and then putting your finger on top of the Capio device, leaning your weight into it and firing. And then after you've fired, lifting the device up and out, and then palpating to see where your suture has gone through.
My training is complete. I think you can leave us, Victoria. You've done a great job.
Yes.
So the tips and tricks of sacrospinous fixation, you have to understand that the sacrospinous ligament is like a V. So if that's the ischial spine, the sacrospinous ligament has a cranial and a slightly caudal component. If you feel the spine, below you will feel the pubococcygeus muscle. This is not the ligament. The ligament is the cranial part. And the cranial part is where you want the sweet spot. It's 1.5 centimeters medial to the ischial spine. So that's the sweet spot of the sacrospinous ligament. So that is the tip, because if you go into the muscle, you will get that buttock pain, you will get that nerve pain, and then Victoria said she put her hand up that it did go in once, and it's all good. This is all part of life. So this is the tips and tricks for sacrospinous. I hope they were of some help to you. Thank you.
Yes. What is the difference between partial and complete colpoclysis? June wants to know. Partial and complete.
Not a lot. I think that people who try and do what's called partial colpoclysis, it's like a Latsko type procedure where you're really trying to only obliterate the upper half of the vagina. It's very, very difficult to stop that from breaking down. So partial Lefort's colpoclysis is a total colpoclysis. Latsko's colpoclysis is a kind of partial colpoclysis. I don't think you should ever think that a colpoclysis should be coitally competent. Colpoclysis is what it means. Kolpos means vagina, clysis means closing. You're closing the account, no deposit there. And a good colpoclysis will work best if you do what is called an aggressive perineorrhaphy, not a perineoplasty, an aggressive perineorrhaphy. So if you want your colpoclysis to work, you can do your 2 rectangles, which is what we call the traditional Lefort, or you can do the John Delancey 7 per string colpoclysis, followed by an aggressive perineorrhaphy.
Yeah. Is caliplication still to be used?
Well, I mean, it's almost out of fashion now, Lashmi, almost out of fashion. I don't think Victoria has done any caliplication, nor has Tanvir when she has been with us. She hasn't done any caliplication. We hardly do them yet.
Can I interrupt with something that I think?
Yes, please. Yeah.
Just 'cause we were talking about the capio and the sacrospinous, someone's asked whether it's single use, and I think Prof is a good time to bring up. Obviously, we're a very different resource country than India, but in COVID, we've just discovered that we've had a paucity of sutures, and Prof actually reused one of the sutures, I think, in a very ingenious way. So the sutures are meant to be single use, but if anyone's used them, or do you want to continue, Prof?
No, you go ahead. I'm listening with great interest.
So the sutures are meant to be single use, and if anyone that's used one end has a bullet on it and the other end has a suture. And so those sutures at the moment in Australia are very difficult to get a hold of, but the actual device is not. And so Prof actually used it on one, so same patient, not different patient, but used the device on one side and then used actually, so the same bullet, but a Mayo suture or a Mayo needle on the other side so that he could actually use the same length of suture twice on the same patient.
So you have to be creative. That's number one. Number two, I can tell you that in Ahmedabad at this moment in time, there is a device being prepared by myself and Dr. Vineet Mishra, which is a capio-based device, which we want to really produce very cheaply. And we have some problems at the moment due to COVID, but eventually, I think it's a great device. It's easy to teach, and I think it should not be as expensive as it is nowadays. But yes, we are going to make one very soon, I hope. When COVID sort of calms down a little bit. I think it's going to take a long time to calm down, Mr. COVID, but it's going to happen. Yeah.
Yeah. So can I go to another question? Dr. Mamta Chabra wants to know how to look for enterosealing precedentia.
I would not worry, Dr. Chabra. I think if you've got a precedentia, you have an enterocele anyway. So it really depends on how do you want to tackle the precedentia. If you want to do a palliative procedure, then you don't need to worry about enterocele, you just do a colpoclysis. That's a palliative procedure, okay? If you want to do a definitive procedure for a precedentia, you most likely will end up doing a vaginal hysterectomy. And when you do a Hymakol after the vaginal hysterectomy, which you must do on every single patient, you will take care of the enterocele. So you don't need to worry. If you have a precedentia, which means everything is hanging out, then you 100% have an enterocele anyway. You don't need to worry specifically about enterocele.
Dr. Manisha wants to know how does etiopathogenesis differs in long cervix and short cervix?
You know, I think, is it Manisha?
Yes, Manisha.
That's one of the cleverest questions, actually. That is a question that took me a long time to understand. The etiopathogenesis is different because if you look at nulliparous prolapse is always got a long cervix. That's because the ligaments never break, they stretch, okay? And that's because of congenital collagen problem. In some women, you will get uterocervical prolapse with a short cervix because they have had sudden trauma to the ligaments, usually during childbirth, and the entire uterus falls down. I am sure if you've delivered enough babies, you will sometimes see that the woman's given birth and the cervix is still at the introitus. And after 6 weeks, it does go up, but it's there. That means those ligaments actually stretch. They are not broken. Because if the ligaments are broken, that cervix will not go back. It will still stay there. So the etiopathogenesis is very, very important. And I think that you must always check what the length of the cervix is before you start doing any corrective surgery for uterocervical prolapse. The etiopathogenesis is, as you said, short cervix is breakage of the ligament due to sudden trauma. Long cervix is due to a gradual stretch against gravity. And a long cervix does not remodel. So you cannot actually push the cervix back in and do some kind of uterine suspension operation. It never goes back. It always keeps coming out.
Dr. Mamta Chabra has two questions for you, Dr. Rane. She wants to know about paravaginal repair and where to look for lateral sulcus.
Okay, so two different things you're talking about now. Paravaginal sulcus is something that you can examine just looking at the anterior compartment. I am sure Tanvir does the same thing like we do. So basically, if you have a non-rugous, smooth prolapse, your assumption is that this is a central defect. If you have a very rugous anterior prolapse, your assumption usually is that it is a lateral defect. The best way to try and find this is by taking a sponge holding forceps and go below the level of the bladder neck and gently place it on either side of the prolapse. And by pushing the two prongs of the swab holding forceps, if the prolapse goes up, then it is a paravaginal defect. If the prolapse stays in between your swab holder, then it's a central defect. However, laparoscopic or transvaginal paravaginal repairs haven't shown a lot of promise despite numerous series being done. So we prefer to do anterior apical prolapse repairs, and they seem to do extremely well in our hands. Either you do them with a sacrospinous fixation or without a sacrospinous fixation. So we focus more on the apical fixation of the anterior vaginal wall rather than the lateral fixation. I think when you put the apical fixation together, it usually takes care of the lateral sagging. Yeah.
Can we just do the examination with our fingers other than a sponge?
If you've got fingers as long as a sponge holder forceps, yes. But because your fingers might be short, you have a tendency to push the whole vagina. What you don't want to do is push the whole vagina. Any prolapse will disappear with your two fingers if you push it in. What you really want to do is keep something long and then just replace that part, right? And then if there's a prolapse still in the middle, then that's just an, but yes, of course you can. I mean, that's what they talk about, training the fingers, right? All we do, and you've seen this in our unit, we don't have fancy equipment. We use our hands, our eyes, and our ears, 700 to 800 prolapse patients a year. That's all we use.
Yeah, so can you tell them about your full thickness, just a little bit on anterior, how you fix it to the cardinal? I think that's something which has to be very clear.
I know you like that operation, and the one you videoed wasn't that crash hot. You missed one step, right?
Yeah.
But what we might do is I'll give you the responsibility to putting a compilation of our videos, and maybe that would help. It's really difficult to explain it without actually the video. What do you think, Victoria? Is it easy to explain the Musprac operation without a video or without a live patient? Because I know you struggled with it for a long time as well.
No, I think you need a video, a step-by-step video.
Yeah, okay. So we will make one of those for Manisha, I think. Is it Manisha? Whoever.
Yeah, that's a good idea. I saw some people asking for videos, so that would be nice.
Dr. Rane, Dr. Sandeep Nikhade wants to know what should be the diet plan after 4th degree perineal tear repair.
Yeah, I saw that and I thought, why is he asking
you
me
have to answer, he's my friend.
But that's a really good question. You know, a lot of people actually always struggle with this. I think it's very important that you have a standard plan for 3rd and 4th degree tears. Number one, do not constipate the patient. So give them full diet, okay? Number two, give them stool softeners. Stool softeners can be in the form of Dufalac, lactulose, Do not give them rectal stimulants like Senocot or Poloxil, but give them stool softeners like Osmolax or Actilax. Okay. Third important thing is, yes, I think you should give all patients antibiotics for 5 days. Fourth, lots of pain relief. There is no such thing as sitz bath. Sitz bath is gone. It's gone with Dr. Sitz, maybe about 30,000 years ago. For perineal, 4-degree perineal tear, the perineal hygiene is simply with water. Just wipe the wound with water after every bowel motion, full stop. So I like the question, and the answer is very clear. Full diet, do not give them, constipate them, give them stool softeners, and everything will be fine.
Yeah. Dr. G. Somini wants to know your experience and follow up with APG, PeriG, and ApoG procedures.
Yeah, look, I think that's a very sore topic, but I will tell you.
That's very,
So there is a big problem. Who is this? Who asked me the question? But whoever it is, yeah,
Dr.
Dr.
Somini.
Okay. So let me tell you. I will tell you what our experience has been, as honestly as one should. So the bottom line is, we were the first people in the world to perform these operations. We performed the first 40 operations in the world in the month of April in 2004. We are still following these patients, and none of these patients have sued us. None of these patients have actually had any major problems. Why? That's the question. Why? And the why is because of patient selection. The why is because of proper diagnosis. The why is because of proper surgery and proper follow-up. So I think there were some very important components that we had in our study protocol. So we actually only operate on women over the age of 50. Now that's being ageist. I understand what you're saying, but that was the protocol. We made sure that we only operated on stage 3 and stage 4 prolapses. There had to be recurrences, both in the anterior compartment and the posterior compartment. Women were given at least 16 weeks of vaginal estrogen. We did full thickness tissue dissection, and we did what is called as a tension-free mesh placement. So there were lots and lots of different things that we did. And so our experience of these products, and so I mean, I have to tell you, these products are no longer available. They have been discontinued in the world because of the whole mess that has occurred due to improper use of mesh. But our experience has not been a bad one. I hope that answers your question. But it's not because of the product. It's good patient selection, making sure that you're meticulous with the surgery and good follow-up.
Dr. Purnima Ranka wants to know pessary is suitable for which group of patients and how to choose the size.
Yeah, that's a really good question. So pessary is a bit of a hit and miss phenomenon. And maybe Victoria was laughing. So that's because recently she is closing down my business because she's using a lot of pessaries at the moment. And one of the things that happens is quite a lot of the women come back with pessaries in their little plastic bags, which they fall out. So how do you assess the size of the pessary? I will tell you. So basically, if you have a prolapse, you need to replace the prolapse with your finger. And where your finger is underneath the symphysis pubis, after you replace the prolapse, is the diameter of the pessary that you want to use. Make sense? So underneath the symphysis pubis where your hand is, that's how you size a pessary. However, if women have had previous surgery and they have a narrow introitus and a prolapse at a higher level, so introitus is narrow because they're old, but they have a level 1 prolapse or a level 2 prolapse, it's very difficult to get the pessary in and even more difficult to get it out. So you need to be very careful when you're actually sizing the pessary. You also need to look at the level of the introitus. I still think it's a trial and error thing. You have to tell the patient. And the problem is that I don't know how expensive pessaries are in India. but you have to open one packet, then you have to open another packet 2 weeks later, then you have to open another packet 3 weeks later. And, if you're going to keep charging the patient for the pessaries, then I think you're rapidly going to run out of patients. So you need to be very, very careful about how you counsel the patients with pessaries. What's the story in India, Tanvir? Do you use pessaries?
That is another question. How often pessary should be changed, Dr. Rani?
Yeah, sure. So what do you think, Tanvir? How often should a pessary be changed? Do you use pessaries?
Very less, Prof, but I think we've just used in a couple of patients who don't want to get operated. So that's when we do give them. And we if it fits well, we just ask them to continue and come back for a follow-up. So I think I've changed it in about 3 months.
Yeah, that's pretty reasonable. We would change them every 3 months as well, and make sure that they're using vaginal estrogen.
Yes.
Because I think that is very important. It keeps the vagina moist. Because the biggest problem of pessary being in there is the pressure it puts on the vaginal walls. So if you don't have enough moisture, then it keeps like almost making the vagina pressure necrosis, right? So you got to be very careful. Yeah. Good.
Dr. Indira Rani wants to know what suture material you use for sacrospinous fixation.
A good point. That's a very good question. So we actually used to use PDS. Now we use Proline because our experience is that if you put a PDS suture, we had definitely had a higher risk of recurrence. Yeah.
Hello. And Dr. Yoga wants to highlight the tips and tricks and prevention of vault prolapse. Which surgery is best? How to prevent vault prolapse?
Okay. Yeah. Gotcha. Okay.
Yes.
So, yeah, prevention of vault prolapse. Very important question. Very, very important. Okay. Who are the worst surgeons for causing vault prolapse? Gynecological surgeons doing TLH, because they do not put the vault support back together. They're the worst culprits. The laparoscopic surgeons are the worst culprits because they don't usually reconstitute the pericervical ring. I know, Tanvir, you're saying you want to put your finger up for something, but yes, take your finger up. What do you want to say?
I think, Prof, who do it laparoscopically but close the vault from below, from vaginally, that's where you have the problem. If they close it laparoscopically, I think they do take in the uterosacrals.
No, rubbish. I've seen a lot of people who close the vagina with your stratasys or your V-lock, and they just want to close the vagina. I think that is the concept, which is the wrong concept. You understand what I'm trying to say? So you really, V-lock has made life very easy for laparoscopic surgeons, because then you don't need to knot, right? So I think once V-lock came in, people just want to close the vagina and go home. And I think that's where the biggest problem is. So if you look at the incidence of colporexis means that the woman's having sex and next thing her small bowel is hanging in her vagina. Colporexis. The incidence of colporexis is highest amongst TLH patients. Okay? So it stands to reason that what I'm really trying to say is if you want to prevent vault prolapse, laparoscopically make sure you reconstitute the pericervical ring properly, take your uterocycles. I don't have a problem with closing the vagina vaginally after laparoscopic surgery, provided you do a semi-McCall at the same time, right? So that is what is important. So if you're doing vaginal surgery, then you must attempt a McCall caldoplasty, because there is lots and lots of evidence to show that your recurrence of postoperative enteroceles is less than 5% at the end of 20 years. So you must do a McCall's after vaginal hysterectomy. You must do a vault reconstruction after total laparoscopic hysterectomy. You also must do a vault reconstruction after total abdominal hysterectomy. They're all the same. It's just different routes. But the principles are the same. If you're cutting the ligaments to get the uterus out, you got to put them together. You can't just cut and run away and hope for the best. So when you're asking how do we reduce incidence of wall prolapse, if you're doing laparoscopic hysterectomies, reconstitute the vagina, attach the uterocircles to it, as Dr. Tanvir does. You can go to Hyderabad and have a look. If you're doing a vaginal hysterectomy, different ways, people do McCall coloplasty, some people do high uterocecal ligament plication, but be careful with the high ligament. But McCall is quite easy. Might ask Victoria's experience on her couple of McCalls that she's done with me. But what do you think? Is it an easy to learn procedure?
I think once you've seen you do it and explained, I think it is. I know we tried to make a video and explain it, and I think it's still difficult. I think it's one of those things you need to see and do and be instructed through.
For the ultra high ones, yes, because I think that gives you the best result, the high McCall, and done in 2 halves. And that's the one we will make a video of, Tanvir. So we're going to make a video of the anterior musprac. We're going to make a video of the high McCall. I'm not going to do any other videos.
Yeah, very good take-home message as far as prevention of wall prolapse is concerned. She wants to know which is the better treatment for apical prolapse, sacrocolpopexy or pectopaxy?
Oh, sorry, I missed that question completely.
Which is the better treatment for apical prolapse, whether it is sacrocolpopexy or pectopaxy?
Oh, well, actually, I don't even know how many people know the word pectopaxy. So the commonest operation done all over the world is colposacropexy, right? But for I don't know who is the person who's asking the question. The pectopaxy has been made popular by Gunter Noy, who is a good friend of mine from Cologne in Germany. I don't think that pectopaxy is something one would consider doing without learning it properly. I think that's a very important thing to understand. I think it's the same is true for laparoscopic colposacropexy as well. But what I'm trying to say is, so if you ask me which is a better operation, colposacropexy versus pectopaxy, then Gunter's group has done a randomized trial on it, and they've shown that both of them are the same, except that the colposacropexy group had some higher bowel problems. On the other hand, even though Gunter is my good friend, I think that the pectopaxy gives the vagina and the apex an unusual angle or axis. It's not a physiological axis. That's it.
Yeah. Dr. Kishore Rajurkar wants to know what is the importance of supravaginal elongation vis-a-vis intravaginal elongation.
Virtually nothing, because once you open the pouches, it doesn't matter whether it's supravaginal or intravaginal. I think what is more important to understand is that if you are going to do a conservative treatment for that prolapse, which has got an elongated cervix, no operation, sacrohysteropexy, bilateral sacrospinous hysteropexy, or any of these operations are going to work unless you do cervical amputation. And therefore, you have to dissect the bladder off anteriorly, you have to dissect the vaginal wall posteriorly and find the spaces, amputate the cervix, and then do whatever you want.
Dr. Haritha wants to know in which case of anterior prolapse, how to assess which needs apical correction and which do not.
Yeah, so actually that's a very good question. It is very rare for anterior prolapses to occur, in my opinion, without apical prolapse, really. So in fact, we very rarely do an isolated level 2 cystocele plication without any apical procedure. 99.9% of our operations for anterior compartment involve an apical procedure. So I would recommend that you actually attempt to do some kind of apical fixation for every single cystocele you look after, unless it is that Indian cystocele, which they call the mild cystocele, which does not exist. Full stop. When you talk of cystocele, it should be at the level of the hymen on straining. Otherwise, it's not a cystocele. It's just normal vaginal mobility that you are making immobile for your bank balance, which is not a prolapse repair, right? So then you don't need apical fixation. You don't need anything. You might as well just cut and suture and be happy. But I think if it's a genuine cystocele, you will need to do some kind of apical procedure, and you will never regret it because it really helps the patients.
Dr. Rane, you have received almost more than 100 praises for the way you have explained this complex.
I like Usha Chawla.
I'm sure you are reading it, because if I start reading, it will take another half an hour. But I will still prefer that you answer 3 or 4 more questions. Somebody has asked, I'm not leaving you. Bladder care after anterior colporrhaphy.
Good.
Should be the bladder care.
Victoria, bladder care after anterior colporrhaphy. She's smiling.
Yeah, because I'm trying to pick up very practical, basic questions which every gynecologist needs to know. Yeah.
Am I assuming that in bladder care we're talking about a trilobvoid?
Yeah, I mean, it's just they have asked you what should be the bladder care after.
So what do we do after an anterior repair? Nothing.
Well, we do a formal trilobvoid.
Yeah, but I mean, as in, there's no catheter.
No. So
there is a pack only for an hour.
Yes. So I've operated with people that leave a pack in overnight, so more than 12 hours, or leave a catheter in overnight. And I think one of the things that I've learned this year is that you don't need to do that, and you actually can do these things as a day procedure. So as Prof just said, we leave a pack in for an hour. We don't put a catheter in, so we do an in-out catheter at the time of the operation, and then ask all patients or nursing staff to have patients void 2 hours after they leave theatre, or at least try and void. And we do a formal trial of void. And do you want me to do our 4 scenario trial of voids?
Not yet.
Yeah?
So
okay.
Mostly after any pelvic floor surgery, you will find that our patients don't have catheters. They only have pack for only an hour, because we believe that the dead space should be corrected during surgery, and the small troublesome oozing that you may get, you only get within the first hour. If after 1 hour you remove the pack and there is lots of blood coming out of the vagina, the pack was never going to stop it. So we don't leave the pack for more than 1 hour. And then after 2 hours, we ask them to void. And then depending on their post-void residual, we see what their treatment is. But in essence, we are minimalists. We don't use catheters and we don't use packs.
Another basic question, Dr. Rane, what works best for the decubitus ulcer before surgery?
Yeah, good point. I think the best thing that works for a decubitus ulcer before surgery is putting the decubitus ulcer back in. That might not be as easy as one thinks, because really it's what is called a vascular ulcer. It's a devascularized tissue that causes the decubitus ulcer. So if you can replace the prolapse, and one of the things that in India we used to do very well was the glycerin max sulf pack. And as a junior doctor, oh my God, my hands used to hurt. I used to put so many glycerin packs, and then sometimes we used to forget them. But it does reduce the edema of the vaginal tissue and does help the healing of the decubitus ulcer. What I'm really trying to say, however, is nowadays, with good diathermy techniques and hydrodissection techniques, you don't need to wait for the decubitus ulcer to heal. You can operate pretty much straight away with the decubitus ulcer. Just excise it.
Dr. Sudesh Agrawal wants to know your take on cervical amputation in a case of young long cervix cases, in young
Yeah.
patient who has got long cervix.
Yeah, no, I doesn't do so. As soon as you say young, even I'm young. So I think it's very important that we understand what you mean by young. So I'm going to define your young patient. So what do you mean by young is a patient whose cervix is coming out, but she wants to have more babies. If you want the patient to retain fertility, please do not excise or cut the cervix. They don't do very well reproductive wise. You might have to do IVF and stuff like that, which every Indian doctor thinks he's an IVF specialist as well. So I would recommend you not to do cervical amputation. So then what do? She's saying my cervix is hanging out. What am I going to do? So yes, you can try a pessary to see if it sits up. Yes, you can try a sacrospinous hysteropexy, telling the patient that your cervix will go in, but it will not go in all the way. It will still be in the mid-vagina. Have your babies. This operation will definitely eventually break down, and you will need to have a vaginal hysterectomy and removal of your cervix. So all our experiences of using sacrohysteropexy, of using sacrospinous hysteropexy, with an elongated cervix, the results are temporary. They should only be used for women who want to have children. And after that, the elongated cervix never, ever remodels. It remains long, ever.
Dr. Kishore Rajurkar wants to know which patients of genital prolapse you will offer laparoscopic repair.
No, I don't really believe in that. I think we are good at every single route for doing laparoscopic and vaginal repair. I think the important part is to understand that you must give the patient what the patient needs, not what you know how to do. So, for example, we go by the patient's age, the patient's stage of prolapse, the level of prolapse, the comorbidities, obesity, all these are very important factors in choosing what route of surgery you'll use. There's no point in doing a 4-hour laparoscopic robotic colposacropexy in a 90-year-old woman who is 100 kilos in weight and who has had 4 stents and is on warfarin. That's a joke, right? But we see this from time to time. So I think it's not a question of whether you can do laparoscopic surgery or not, whether you can do vaginal surgery or not. You should be able to do both as a pelvic reconstructive surgeon, but you have to weigh everything with the patient. So our dictum for the patient selection of surgery, yesterday we asked this discussion because I'm going to take one more question and then go to bed.
Yes. Yes. What Meena wants to know.
So our counseling technique is you talk, she talks, you talk, she decides. That is how your dialogue should go in clinic. You talk, she talks. You talk, she decides. That's the first important part of how you come to a decision what surgery should be done. Second, I call it the mother test. What would you do for your mother? That is the correct answer for the patient. Not necessarily your mother-in-law, you may not like her too much. Or even your wife, you might want to kill her. But your mother, you will never harm. So if the answer to your question is, patient come and say, well, doctor, what will you do? What do you recommend? Most patients will tell you that. What do you recommend? You say, I'm going to do the mother test. In my hands, I would like my mother to have a vaginal hysterectomy and a sacrospinous fixation. In my hands, I would like my mother to have a laparoscopic colposacropexy. So that's the way, if you practice your medicine that way. First, you talk, she talks, you talk, she decides. Second, mother test. You will never go wrong. Never, ever go wrong.
What are the indications for mesh repair? And which suture material to use if you are going for mesh repair?
We don't do any mesh repairs anymore, sadly. No mesh repairs except for laparoscopic colposacropexy. No mesh available anywhere. And I don't think anybody will be using mesh, sadly, very sadly, because these operations, the mesh repair operations, did benefit about 15% of difficult prolapse patients. And unfortunately, those 15% of difficult prolapse patients are not going to have that available, sadly. But that's life. It's beautiful. And I'd like to thank both my fellows, Tanvir and Tori. It's very late for Victoria. It's 10:30 in the evening.
Yes.
And Tanvir, for joining us as my panelists. They've saved a little bit of my voice because I think I'm suffering from webinaritis.
And thank you so much,
But
Professor Rane,
as well.
for
Thank you.
patiently answering all the questions. You have practically, I have avoided only repetitive questions. Apart from that, you have really answered all the questions, and I'm sure all the participants are very happy for you. Thank you so much.
Thank you. And can I just say, before I go, that all the people who have been asking questions, and you have written some very, very kind words about me.
Yes.
And also, I'm very, very grateful, very humbled by that. And I think the same holds true for my fellows. They're absolutely amazing.
Yes, amazing
gynecologists. They're the future of the world. So I am so proud of them to be here, because that's what every guru needs, is good disciples who will be better than him or her, and they already are. So I'm very grateful to them, and to you, Lakshmi, for having me here.
Thank you. Thank you so much. Thank you.
Bye-bye. Bye-bye. Stay safe.